Thank you all for these fantastic presentations. So I'm going to start off the question amongst the discussion amongst the panel with a question asking, I just want to get all of your thoughts on how would you consider the continuum of peri-procedural care, including the pre-procedural period, specifically with respect to elective surgery? How do we consider intraoperative or inter-hospital care, and then the post-operative period, and specifically touching on transitions of care?
Sure.
How should we consider these with respect to creating practice guidelines?
Well, I think it's very important to look at the whole. Sorry. Thank you. Thanks. I think it's very important to consider the whole perspective of care. So when I'm seeing a patient in my office, in discussing the surgery and the potential risks of surgery, I will now always have a discussion with that patient about what to expect in terms of postoperative pain and how we're going to manage that. And so it's talking to the patients about their expectations, I think, has a huge impact on what they're going to expect after the surgery and how much they're going to take. I'll tell my patients that I'm doing breast surgery on now that, you know, they're not going to need any opioids, and they'll say, good, I don't want any anyway. And then that's the way it is, you know. So you just set that expectation for the patient. Preoperatively, then most patients will receive acetaminophen, and a lot of them are getting gabapentin preoperatively. Intraoperatively, obviously we use local anesthetic techniques on the skin, leave longer-acting opioids either in terms of blocks or even just leaving the anesthetics themselves, injecting them into the wounds at the end of the case. Intraoperative Toradol is common. So I think it's a combination of all of these things that will lead to less opioids being used postoperatively. And I think it's an important aspect to take into mind, because a lot of the use studies that have been published so far really, I don't think, have optimized the description of using nonsteroidals and acetaminophen optimally. So, for example, one of the papers that we wrote, sort of still only 20% of the patients are taking ibuprofen and acetaminophen, and then we looked at their use after that. So I think that the guidelines are going to evolve as providers use more of these alternative non-opioid medications in pain control, and I think you're going to see a lot of the guidelines for number of pain pills that are needed is going to go down over time as more providers use, set expectations for patients and use nonsteroidals.
Just a little to add on to that is that when we look towards having better outcomes, and if we follow Donna Beatty in terms of structure and process, what are those things that we need to do in the structure field and in the structure realm and in the process realm to get to these better outcomes? And if the better outcomes is decreased or zero opiate use postoperatively, what are the things we need to do upstream to do that? And I tried to allude to it a little bit, but one of the things that we have found at the College of Surgeons is visiting hospitals that are performing all types of surgeries and trying to get better outcomes is that we kind of look at things as a continuum of 5 phases of care. Pre-op, all the stuff we do, the diagnosis and the comorbidities and patient readiness and optimization for surgery. The immediate pre-op, which is the 24 hours before surgery, where we make sure that everything that we tried to do in the other setting was all set. And so nurses do a lot of the checklists, and we have checklists with anesthesia and surgery and nursing all together before we get into the operating room. There's obviously intra-op stuff that anesthesia and surgery does with the patient. Post-operative, if inpatient, if it's an inpatient procedure, and then post-discharge. Those are the 5 phases. But if we want to get less opiates in the post-discharge phase, we need to really think about the 4 phases ahead of time. What we've learned from the enhanced recovery after surgery, or ERAS, is that it usually works better, not usually, nearly always works better if it's multidisciplinary. So we know that the protocols that the surgeons do, if they operate minimally invasive versus open, helps. We know that if anesthesia gives less fluids than more fluids, that helps. If we do multimodal pain therapy, that helps. If we talk to the patient and set expectations beforehand, that helps. And it's really a multidisciplinary phased team effort, partnership in doing these things. And then the final thing is standardization. The more that we can standardize, not just the post-operative stuff, which I think that's what it sounded like the FDA wanted, but upstream, how do we standardize those things to give ourselves a better chance at discharge? So those are the three things.
I would just say that of those three phases, I think that the preoperative phase is the most important, and I would move upstream from preoperative to acknowledge that most of the conditions that we're talking about up here, not just in our specialty, but in all the specialties, are what we call preference sensitive. So surgery is not the only option. There are many options for treating these patients. And so understanding and screening ahead of time for certain types of behavioral traits that may portend a poor outcome from surgery is important. So in our case, we use something called patient activation and pain self-efficacy. And we evaluate those things, and then we incorporate that into our shared decision-making conversation with patients and show patients that have poor pain self-efficacy or low activation that their likelihood of achieving their goals with surgery is low. And so we divert them into a different type of pathway, and maybe in the future, once we address those things, come back and consider surgical treatment. So I think that's the real critical part of all this, is not to assume that surgery is the right answer and to do some upfront assessment. And then intraoperatively, we of course use multimodal strategies that have been described. And then postoperatively, I think it's important that you have frequent contact and assessment of the patient. So there are a lot of programs now that do either phone calls, or there's even more digital apps that are available now for connecting with patients. And we found that patients having that outlook to that outlet to connect with us and get their questions answered, is this normal, should I be feeling this, et cetera, are less likely to rely on opioids, less likely to have refills, and less likely to become dependent.
Those were really interesting comments. I just want to relate an anecdote that echoes that, but also with the caveat that these sorts of sophisticated prehabilitation or pre-op techniques are not widely available in the United States. I mean, most of us are working in academic, urban medical centers where the resources are available, but you go 20 miles away and they're not. I worked at Seattle Children's Hospital for a number of years, and one of our orthopedic surgeons started a program to perform a surgical procedure called the Elizaroff procedure, which is a limb lengthening procedure. And he had the foresight to know that pain management was going to be really critical to his success postoperatively, and referred all of the patients for Elizaroffs to the pain management team and also to child psychiatry. And if we identified patients who had high catastrophizing scores, a lot of trait anxiety, dysfunctional home environments, et cetera, he wouldn't do the surgery on them. We would try to address and fix some of those things pharmacologically or with psychotherapy, and the surgery might be delayed 6 months or a year, and it might not be done at all. But that was a brilliant thing to do, and I think it helped achieve his success rates. But realistically, child psychiatrists, child psychologists, pediatric pain management specialists, they're in very, very short supply nationally, and I think the same thing's true for adult psychiatrists. And identifying those things preoperatively allows you to achieve success and minimize problems with pain and therefore opioid prescriptions. But realistically, that's not going to be an easy nut to crack nationally.
I'd like to endorse but not repeat all of the wonderful things that have been said already. I definitely think that trying to identify high-intensity pain people preoperatively are incredibly important. There are some very sophisticated ways to do it. There are some less sophisticated ways to do it. Certainly when you're talking about chronic pain patients or patients on maintenance therapy and such, there's some fairly good guidelines as to what to do with those patients. And those need to sit side by side with any kind of opioid restrictions and such.
I certainly would agree with everything that's been said previously, although I would point out in two things. One, in dental surgeries, post-op pain management of dental surgeries, 9 times out of 10, the patient isn't in pain when we're prescribing. What we're doing is making a prediction that they are going to need an opioid. And our data would suggest that probably only 20% of the patients really need an opioid. 20% don't fill the prescriptions or don't use it. So we're really kind of in a little bit of a blind prescribing problem. We get accused of over-prescribing, but in fact what we're prescribing is for those 10 or 20% who really are going to need it. We don't know which 10 that's going to be. I will tell you, if you decide to get your kids' wisdom teeth out in July in an academic center, it's likely that these will be new residents and the surgery will take 2 hours instead of 20 minutes. Those people will probably need opioids. Just a hint in terms of taking your kids to a surgeon with new residents. But other than the duration of the surgery, we don't have any specific indicators of how much pain they're going to have postoperatively. So it does create a problem for us, one. The good news is, and I'll ask the other surgeons at the table, we use ibuprofen pretty aggressively. I mean, and out of my institution, they will prescribe 80 milligram doses, which is 4 Advil, with acetaminophen. But we aren't concerned about bleeding because, one, ibuprofen doesn't cause a lot of bleeding, but two, if you get a bleed after oral surgery, you can put your finger on it. It is not a significant risk. And I think other surgical situations where you're going to have to re-anesthetize and reopen a belly, that changes the things you can do therapeutically compared to what we do in oral surgery. So, thank you.
Great. Thank you all so much. So I'm going to open up the questions now to our committee for our panel. Don't all jump at once. Dr. Chow.
Hi, Roger Chow again. Just a quick question. So a couple of you all mentioned that sometimes you kind of lump procedures together anatomically or by some other criteria. I'm just wondering, what kind of framework do you do for that? I mean, just thinking about how many, hundreds of surgical procedures there are and variations and how they might all potentially be associated with different levels of pain, and we don't have data on many of them, or at least not good data. So do you have some kind of framework for doing that, or is it just kind of by feel and experience, or what how do you do that?
Hi, so I was one of the people who brought up the anatomic site, and I would actually defer to our anesthesia colleagues in this regard. So there are probably 10,000 CPTs for operative procedures, and so whether we want to clump or split, I would think that we would want to clump those 10,000 if you're going to write guidelines, or think about the principle of the framework of the guideline. So then, how would you clump it? And maybe anatomically is at least how a lot of times we do it in the operating room. The anesthesiologist doesn't care what we do in the abdomen. I mean, they do, but not to the point of like, well, all right, just tell us where we need, if we do, for example, an epidural, or we're going to do a block, if they're going to do a block, where is that going to happen? And it doesn't matter. I mean, if the gallbladder's here and the liver's here and the split, whatever. If it's below this, then that's fine. And so anatomic might be a very good way of kind of clumping things together. Now, when I did ask people like, well, would that make sense, and this and this and this, and then people started to kind of get into the details of, well, are you taking out the colon for a cancer? They're going to have cancer pain, or diverticulitis because they're going to have inflammatory pain of the visceral lining of the abdomen, or is this going to be just because they're having adhesions or whatnot? Then you get into kind of branches of the tree of within an anatomic site in the disease process and severity. So I think that anatomic would be a good way to clump, but then have to deal with a lot of the other kind of branch points from that point.
I think there is some good evidence, Roger, I think, to answer your question, and that has to do with the use data that we've seen. So, for example, if you look at the number of pills required to take care of 80% of patients' pain that have had either lap appies or laparoscopic cholecystectomies or laparoscopic hernia repairs, it's all the same. It's about 15 pills, right? So I think you can group those laparoscopic procedures together, and from a mechanistic standpoint, it makes a lot of sense. But we have evidence actually that shows that that's about how many pain pills will satisfy most of the patients. So I think if you kind of go through the list of some of these procedures, that there will be several that can be grouped together and be able to give us a similar amount of pain pills for.
Just to add briefly to that, I would say that I agree with Cliff that the anatomic designation can be helpful, and certainly in our case, there's certain joints that are more painful than others, like knees. But for us, really, when we think kind of teleologically how we separate them out, we think about inpatient versus outpatient. We think about open versus arthroscopic, and then we think about the duration of the procedure. As well as whether it's elective or non-elective, so fracture versus something that's elective.
I'd say for the general non-orthopedic cases, much of what's said here, so open versus laparoscopic or minimally invasive is a big difference. Organs out versus organs stay in seems to be a real difference. Certainly, if you start layering on top of it reconstruction or major oncologic disease, that usually is more tissue disruption and mediators and such, and we find more pain management issues.
Right. We'll go in order of the cards. I think Dr. Delgado has card up next.
Thank you for the great presentations. A related issue to, I think, the one that Dr. Moore was speaking about in terms of NSAIDs and acetaminophen. I guess the first question is to Dr. Bozic. In orthopedics, I know there's been concerns about bone healing with NSAIDs, and I wonder if there's a consensus within the specialty on the evidence regarding that. And then the second question is, the most common formulations for opioids include acetaminophen, and whether there should be guidelines specifying the use of the common formulations that have acetaminophen with, also taking extra acetaminophen or Tylenol, or whether should maximize, take extra Tylenol plus ibuprofen, and if you still have pain, should we be prescribing Oxy-IR or ones without acetaminophen in it to maximize the opioid-sparing effects?
I'll just take the NSAID question. This came up at the break, and certainly there is some basic science evidence that suggests that NSAIDs can interfere with bone healing, specifically non-selective NSAIDs. There was a recent Cochrane review that's about 18 months old that was published on this topic, and the gist of the review was that the evidence is inconclusive. Most of the evidence comes from basic science, and in clinical evidence, there's very little, if any, evidence to suggest that it interferes with bone healing. There's 3 clinical scenarios where people get concerned. One is fracture healing, the other is bone ingrowth to an uncemented prosthesis, and then the other is spinal fusion. But again, our opioid pain toolkit, or our pain relief toolkit online, has a recommendation from the AAOS that NSAIDs do not interfere with bone healing and therefore are not contraindicated in those scenarios.
So there were 3 questions on this side. I don't know which was first. Dr. Polimano?
Oh, hi, everyone. I'm Steve Wiseman from the Medical College of Wisconsin in Milwaukee, not Madison. And I heard 2 interesting themes in most of your presentations. One was one of condition-specific surgical procedures that are likely to need opioid. But then the last bit of conversation has really focused in on things like ERAS, the perioperative surgical home. Essentially, how do you reduce or avoid the use of opioids? So, and then lastly, and maybe most importantly, when my wife had her total hip arthroplasty, she used 2 doses of opioids postoperatively, and had a very different experience than we'd be apt to talk about. So it offers me insight into the fact that maybe we're asking the wrong question. Maybe the question isn't what procedures do we need opioid for, but really, what are the best ways to manage these different operations when it comes to the perioperative discussion? So I'm curious about how and what people have to say about that.
Well, I would agree 100%. We had a call amongst this group on Friday, and that's what was the discussion on the call, was that ultimately we want to think about opioid-sparing strategies for all of the conditions that we treat, operative or non-operative. And so most of what we've done in orthopedics is look at, and there are now trials and there's evidence, and some of them were cited in our clinical practice guidelines, looking at which alternative techniques, including cognitive behavioral therapy, including blocks, including periarticular injections, can eliminate or minimize the use of opioids.
What you described is actually what's happening in clinical practice broadly, beyond orthopedics.
Yeah, I think what's hard, though, is what I think Dr. Crane brought up, which is that I hope that, as we all know, that many of the clinical practice guidelines that have been developed end up being ignored because they can't be implemented into practice by the average practitioner. And that concept of providing all these different complex services to achieve the goal of reducing opioids may not be practical in one of the small towns in northern Wisconsin, which has a 30-bed community hospital, where nonetheless they're doing big procedures. They're doing total joint arthroplasties, et cetera. So it really raises a conundrum of what the right answer is.
Dr. Palomano, you had a question next.
Sorry, Rosemary Palomano from University of Pennsylvania. So I'm really hearing about the standardization of care, but also those who deviate or have special needs, so the at-risk populations for pain. So our goal is to have these be evidence-based, this framework. And so some of the evidence about behavioral health factors and procedural factors all come from specific populations or procedure-specific literature. So do you have any suggestions for how to organize this at-risk for pain population in terms of the literature in guiding a framework for clinical decision-making?
In particular, with regard to the patients who are chronic opioid users, I think there's a big lack of evidence right now out there in the literature in terms of how to manage those patients. So I know that was one of the issues that was brought up. I think that we should highlight that. It's really very unclear how they're all going to be tolerant, and so we end up giving them more than the guidelines usually, as it is. There've been really important discussions about interacting with their primary care providers or whoever is chronically prescribing them opioids at this point. But whether I've read about things like opioid rotation, like giving them different opioids because they affect different U receptors and things, I think that has to be evaluated more. So I think there's a lot that can be done in that group, but I think we have very little evidence right now to be able to say what the guidelines should be for people who are chronic opioid users.
Thank you.
I would just add that as far as special populations, I think you're pointing out that patients with low pain self-efficacy and low activation are at higher risk. And while the studies have been done individually in certain specialties or procedures, if you aggregated that evidence in the form of systematic review, I think you would find that to be a common characteristic across all the different specialties.
Thank you.
I think it'd be very interesting to hear session 4 when they talk about the guidelines development and the evidence there. I think that if we learn from what we've tried to do in healthcare in terms of putting evidence into recommendations or even quality measures of like, for example, the National Quality Forum, is that it's very hard to make a broad, impactful, sweeping metric or recommendation of something if we're going to be very rigorous in terms of the evidence that needs to be there. And then it runs into exactly what you're saying, that we have it in this procedure. Well, does that mean it for this procedure that's similar to it or not? And then the implementation aspect of it is that if I'm a surgeon that operates here in the belly, but this thing is over here in the belly, is that applicable to me? And if it's, I can go kind of both ways. Like, well, it's close enough, I'm going to do it, or it's not the same thing, I'm not going to do it. And so I think that the implementation piece of figuring out exactly what we're trying to get to, or what the FDA wants, is going to be a big piece of, what is that target, what is that focus, and how to get there. Certainly, the issue of practice guide. We were writing just a small anecdote. We were writing a chapter, a book, and we asked Brent James from the Intermountain Health, who does a lot of guidelines implementation and use in the multiple Intermountain Health hospitals, and has shown great quality from it. And we asked him to write a chapter, and he's like, well, are you asking me to write a chapter for guidelines? Because I think we should write a chapter against guidelines. Like, what are you talking about? And just really, because there's so many not useful, not helpful, not meaningful guidelines out there. And he's like, well, if somebody's going to just develop a guideline, just to develop a guideline to publish a document that is not helpful, then they shouldn't do that. And so that's a real big piece that I think session 4 will hopefully get to.
I think there's, if we have the time, there's something that I think needs to be said that hasn't been said so far, and that is that in spite of what we call the opioid epidemic, the number of patients who are dying in the United States from legitimately prescribed opioids is really rather small. In fact, there's probably at least as many patients, if not more, who die from NSAID toxicity, gastric hemorrhaging, renal failure, thrombotic events, than die from opioid overdoses. The problem with prescribing opioids postoperative are these. Number one, they have a lot of side effects and they have toxicity, and there are some individuals who are susceptible to respiratory arrest, obstruction. Those particularly are the obese and those with obstructive sleep apnea. We need to be careful with that population. The second thing, as was discussed in the previous panel, is that we have a problem with too many opioid tablets being dispensed, when the actual, and Dr. Weissman had that experience, and I've had that personal experience with postoperative surgical pain. We prescribe a lot, but oftentimes that's more than is necessary. And Dr. Moore described the reason why, because when a patient goes home from the hospital, we can't predict if they need opioids for 1 day or 10 days or 100 days. And there are those individuals after knee and hip replacements who are still taking opioids after a year. The implication when we discuss those patients is that there's something wrong going on here. Why are they still taking it after a year? Well, we know that 10% of patients after surgery have chronic pain. So the challenge is, I think, really is to identify those patients, if we can, ahead of time, and try to figure out what can we do to prevent them from needing opioids for 365 days. There's an implication that if they're taking them for 365 days, it's because of some sort of moral weakness or psychiatric disease, and that may be true in some instances, but it's also not true in many instances. So I'll get off my soapbox now and let others speak.
Thank you. Yeah, thank you very much. Thanks to all of our panelists.
Okay,
great discussion.
I'm sorry to have to cut this off, but I do want to give the public a chance to make comments. I want to thank again the panelists for a very rich, insightful, stimulating discussion. And to thank Dr. Walji for moderating it. And I hope most of you can stay for the afternoon sessions where we get to some cross-linking topics. So thanks very much.